بسم الله الرحمن الرحيم. أنا الدكتور ياسر مظلوم زكريا أستاذ النيورولوجي جامعة اسكندرية. It's my pleasure to meet you today. Today we'll talk about CNS development and congenital malformation. To understand congenital anomalies, we have to go back for embryology. All of us knows that neural CNS coming from ectoderm. To understand formation of neural tube, three primordial tissues: endometrium, endoderm, mesoderm, ectoderm. This is the neural tube coming from ectoderm. As we said, neural tube start to bend to form neural groove and neural crest. As we see, closure to form the neural tube or neural cavity. Neural tube related birth defect anterior result in failure closure, resulting in anencephaly, while posterior neural closure defect coming to spina bifida in various types. At 4 weeks of gestation, 3 vesicle stage forming prosencephalin or foreign body, mesencephalin or midbrain, and rhomboencephalin hind brain. 5 vesicle stage start. This is telencephaly to start segmentation to form 2 cerebral hemispheres. After this, behind coming the midbrain or mesencephalin, and at this side forming metencephalin, while hindbrain myelencephalin. This is coming at the time of 4 to 6 weeks, while between 2 cerebral hemispheres there is what we call dynencephalin midline structure. Again, 5 physical stage lateral ventricles communicating with the third ventricle through the aqueduct to the fourth ventricle, in continuation after that to central canal. So foreign prosencephalin forebrain, mesencephalin midbrain, rhomboencephalin hindbrain. After this coming the differentiation of forebrain, start to form cerebral cortex, thalami, hypothalamus, basal telencephalin. Forming the midline structure including the major corpus callosum, and differentiation between cortical white matter and internal capsule. Again, forebrain, midbrain, hindbrain, starting at the midbrain to form the tectum, cerebral aqueduct, and tegmentum. During neural development, the stages are as follows: neurulation, neural tube closure, disjunction of neural cutaneous and neuronal ectoderm, primitive brain flexure, vesicle and flexure, diverticulation and cleavage, neural differentiation, neural migration, formation of sulci and gyri, and lastly myelination and maturation. At the time of 3 weeks, forming a simple vesicle, forming forebrain, midbrain, hindbrain. 7 weeks, starting more segmentation to become more apparent. At 11 weeks, starting more differentiation to forming 2 cerebral hemisphere, and the hindbrain forming the segmentation of the cerebellum and the posterior part of the midbrain. At birth, the cerebellum completely covered and forming the whole the adult brain type. A closure of the neural tube usually occurs between day 20 to 28. Early stage, the brain is a hollow structure without gyri, fissure, sulci. The tube bends, thickened, and develop surface feature. All normal structure appears at predictable interval. Brain usually smooth before 18 weeks of gestation. At 18 weeks of station, Sylvian, calcarine, and cingulate gyrus apparent. Rolandic fissure apparent at 22 weeks, at 26 weeks pre and post Rolandic, 28 to 37 weeks secondary sulci appear, 40 weeks maturation of the station insula is entirely recovered. Migration starts at 7 weeks. The embryonic cells migrate outside from the region of basal ganglia, the germinal matrix, to the site of eventual cortex in successive waves, which are responsible for the cortical layering, 6 layers. They follow along the process of other cells, radial glial, which extend from the ventricle to the surface of the brain. CNS malformation approximately about 1% of newborn. The incidence of malformation is higher in children with intrauterine growth retardation and in multiple pregnancies. Race and geographic factor may be of importance. The development of the brain continues for years after birth, and thus terms congenital anomaly applies for some birth condition that develop postnatally. Inflammatory responses do not occur before the 6th fetal month, and parts may be absorbed without trace of neurological or connective tissue repair. The same anomaly occurs as a result of genetic or environmental cause. Probably the most important factor in teratogenesis is the timing of insult, followed by the specific nature of agent and genetic factors. Genetic factors. Very few cerebral anomalies are caused by simple Mendelian inheritance, but some examples include form of microcephaly inherited as autosomal recessive, 6-linked variety of hydrocephalus, hereditary congenital facial paralysis, autosomal dominant. Some anomalies have a higher risk of recurrence with families. Some anomalies are associated with inborn error of metabolism. Most important group are the trisomies and cytogenic abnormalities like Downs. Others include translocation deletion like Credichat and sex chromosomes like Turner and Klinefelter syndrome. Maternal age is a very important factor. Maternal infection like rubella and cytomegalovirus. Classification of congenital malformation. Disorder of organogenesis, neural tube closure disorder like anencephaly, cephalocele, meningomyelocele with Chiari type 2. Anencephaly is absence of cerebral hemisphere. The absent brain is sometimes replaced by malformed cystic neural tissue, which may be exposed or covered with skin. Part of the brainstem and spinal cord may be missing, malformed. Infants stillborn die within days or weeks. Anencephaly most common CNS malformation. More common in females, thought to occur around 28 weeks of gestation, severe neurological impairment. Pathologically speaking, gross anterior end of the neural tube, large skull defect, exposed brain, posterior fossa, often spared. Microscopically, cerebrovasculosa, disorganized neural tissue, ependyma, choroid meninges, and perivascular connective tissue. Cephalocele is a protrusion of nervous tissue and meninges through skull defect. The defect is caused by incomplete closure of the cranial fold, cranium bifida. Cephalocele usually occur in midline and protrude anywhere along the line from the occiput to the nasal passage, but can present asymmetrically in frontal, parietal regions. Small cephalocele may resemble cephalohematoma, but X-ray show a bony skull defect in their base. Hydrocephalus often occur with cephalocele. About 50% affected vision has other anomalies. Prognosis which depend on the location and size of the lesion. Usually good. Most cephalocele can be repaired. Even large one can contain mostly heterotopic nervous tissue, which can be removed without worsening functional ability. When other serious malformation coexist, the decision of repair may be debated. You can see a large anterior cephalocele protruding to the nasal cavity. In coronal view, we can see the same. Malformed cerebral hemisphere large, small, asymmetric. Gyri may be absent, usually large, multiple, and small. Microscopic section of normal appearing brain and show disorganization of normal laminar neuronal arrangement. Microscopic microcephaly, moderate to severe motor mental retardation, epilepsy often occur. Spinal meningocele, myelomeningocele, and myocele are all usually associated with spina bifida. Meningocele consists of herniation of both the ura and arachnoid through the vertebral defect, the spinal cord remaining in its position. Myelomeningocele consists of all of the above in addition to the spinal cord closed being herniated as well. Myelocele consists of all of the above, but the spinal cord is often flat with CSF leaking into the exposed septum. Hydrocephalus usually occur in association with all the above. Disorder of organogenesis, disorder of diverticulation and cleavage. In foreign brain, holoprosencephaly, septo-optic dysplasia, callosal degenesis. Holoprosencephaly or archenencephaly cover a large spectrum of anomalies from cyclopia to agenesis of one olfactory bulb. The term aims at the failure of cleavage of prosencephaly. In most severe form, there is an anterior holosphere, no interhemispheric fissure with single ventricle. The brain is often smaller than normal, and the olfactory bulb and tract are absent. Optic nerve are absent, and gyri are broad and have an abnormal pattern. Brainstem and cranial nerve structure may be normal. Cyclopia and agnestia may be major facial association. Occur with embryonic prosencephaly that does not undergo segmentation and cleavage. The anterior midline brain, cranium, and face are abnormal. The malformation may be caused by defect of sonic hedgehog gene. Severely affected features may die before birth. Holoprosencephaly, small brain, single ventricle, various level of separation of hemisphere. Clinically, midline facial defect usually reflects the severity of CNS defects like cyclopia, hyperpolarized disc, cleft lip palate, apnea, seizure, delayed neurological development, association with trisomy 13 and rarely 18 and maternal diabetes. Pathology gross 3 degrees. Lobar, complete intersphere fissure, various degree of fusion, ceramide, semi-lobar, fusion of posterior frontal lobar, a lobar, no lobe, no interhemisphere fissure. You can see the defect. This is semi-lobar holoprosencephaly. Almost single ventricle, preserved thalamide and basal ganglia. Septo-optic dysplasia. De Morsier syndrome is a malformation from the brain occur towards the end of first multiplication and include optic nerve hypoplasia, absence of septum pellucidum, the membrane that separates the front of the two lateral ventricle, and pituitary deficiencies. Although the cause may be multiple abnormalities of particular gene HESX1 have been found in patients with septo-optic dysplasia. Symptoms may include decreased or acute decreased visual acuity in one or both eyes, nystagmus, strabismus, endocrine dysfunction including growth deficiency, growth hormone deficiency, hypothyroidism, adrenal insufficiency, diabetes insipidus, and hypogonadism. Seizure may occur although some children have normal intelligence. Others have learning disabilities, mental retardation, cerebral palsy, or developmental delay. Diagnosed by MRI. All children diagnosed with this disorder should be screened for endocrine and developmental dysfunction. Here you can see absent septum pellucidum. While in coronal, you can see the optic nerve is severely hypoplastic. And if you do more coronal other cuts to see how much thin out the optic chiasm. Agenesis of corpus callosum may be part of complex or of a complex malformation totally partially absent in otherwise normal brain. Partial posterior absent may be associated with lipoma or complete isolated or in combination with other malformation. Bat wing deformity on X-ray, normal isolated mental retardation from other anomalies. Here you can see bat wing appearance or parallel lateral ventricles with separation of the cerebral hemisphere. You can see in midline structure satchel, which best way to diagnose the corpus callosum. Hygiene is totally hygienic, corpus callosum. Another example, in axial, and there is high signal in T1, replacing the anterior portion of corpus callosum consists with this plastic corpus callosum with large lipoma. You can be sure with doing fat saturation or fat suppression, signal has been dropped. Disorder of organogenesis in hindbrain consists of Chiari malformation, Dandy-Walker spectrum, cerebellar Vermean dysplasia, and romboencephalocynapse. Arnold-Chiari malformation, complete deformity of the brain and cerebellum. 4 type, ectopia of cerebellar tonsils may be caused late onset hydrocephalus and may be associated with major deformity of the medulla. Type 2 by far is most common type seen in neonate and usually associated with lumbar myelomeningeal seal, consists of lengthening of the vermis and tonsil of the cerebellum and their downward displacement through a foramen magnum into the spinal canal. Characteristic Z-shaped kink at the junction of medulla and cord associated with other anomalies of cranial bone. A lot of theories for formation of Arnold-Chiari spinal cord is tethered and stuck down in the lumbar myelomeningeal seal, thus not allowing normal ascent during development. This leads to downward displacement of the brainstem and cerebellum. Hydrocephalus is initial event. The motile flexure failed to form. There is argument about all these theories. Malformation occurs early in gestation at the age of 10 weeks. Clear example, you can make the line from the tip of clivus to tracheal hernially and more than 5 mm downward tonsillar herniation. Other example, hindbrain malformation, Dandy-Walker complex, posterior fossa, Dandy-Walker complex, congenital posterior fossa cyst, posterior fossa malformation, classic Dandy-Walker malformation, Dandy-Walker variant, megacisterna magna. Classic triad of Dandy-Walker malformation, cystic dilatation of fourth ventricle, enlarged posterior fossa with upward displacement of trochlear periphery, Vermean dysgenesis. Mild form of Dandy-Walker, varial degree, Vermean cerebellar hypoplasia, minimally dilated or normal fourth ventricle, prominent retrocerebellar CSF space communicating freely with fourth ventricle, keyhole, normal size posterior fossa. Associate anomaly like hydrocephalus, corpus callosum dysgenesis, neuronal migration abnormalities, and extracranial like malformation of face, cleft lip, and cleft palate. Malformation of limbs, digit, hearts, urinary system. Megacisterna magna, mildest form of Dandy-Walker. Largest cisterna magna, communicating freely with pre-medullary subarachnoid space. And this is some people for it at Dandy-Walker variant. Normal fourth ventricle, vermis cerebellar hemisphere. Other congenital posterior fossa cysts like neuroenteric cyst, midline intraspinal posterior fossa, anterior density variable according to the content. Fourth ventricle, vermis cerebellar hemisphere, posterior fossa skull, associated segmentation anomalies, dystrophies. Neuroenteric cyst, arachnoid cyst, midline posterior like less likely CPA, cerebellopontine angle, CSF density diffusion, fourth ventricle, vermis cerebellar hemisphere, posterior wall. Here we can see a large dilatation with large cystic posterior fossa cyst with small cerebellum and vermis. All this Dandy-Walker variant, delta malformation, mild form. Joubert syndrome, congenital Vermean hypoplasia, romboencephalosynapses, this congenital fusion of cerebellar hemisphere. Lermite-Duclos syndrome, this dysplastic gangliocytoma of the cerebellum. And lastly, Chiari type 4, median cerebellar hypoplasia. Joubert syndrome, diagnostic clue, molar tooth, brainstem appearance, bat wing or open umbrella, fourth ventricle, cleft vermis. Clinically, episode of hyperapnea, abnormal eye movement, ataxia, mental retardation. You can see how it looks like, typical molar tooth appearance. Rhomboencephalosynapse. Diagnostic clue: hypoplastic single cerebellum, fused cerebellar hemisphere, absence of severely hypoplastic vermis, narrow diamond or keyhole shaped false ventricle, absent primary fissure, transverse folia. Clinically speaking, abnormal head movement, ataxia, developmental delay. You can see how thickened the cerebellar folia and fused post-cerebellar hemispheres. Lermont-Duclos syndrome. Diagnostic clue: striated cerebellum, thickened ribbon-like folia, bizarre gyroform appearance, T1 hypo, T2 hyperintense mass lesion with hypo-intense striation. Generally, one hemisphere may extend to the pelvis. Mass effect causing hydrocephalus. Clinically, vague neurological findings related to increased CSF pressure, cerebellar ataxia, and brainstem nerve pulses findings. Is PTEN hamartoma. Disorder of organogenesis. Disorder of cortical development, including heterotopic gray matter, lysencephaly, pachygyra polymacrogyra, schizencephaly, and hemimegalencephaly. Ectopia and heterotopia. These terms refer to misplaced group of neurons, such as islands of gray matter in the subcortex, more common in cerebellum than in cerebrum. You can see this abnormal located high signal scattered in subcortical areas. Here, this is typical nodular pattern, almost symmetrical, subependymal nodules indenting the ependyma. Can be mild form like that. Agyra, lysencephaly. This total absence of gyri. Lysencephaly, smooth brain, agyra. Grossly underlaid 2, 3, 4 layers microscopically, no sulci, thick gray matter, thin white matter. You see, very scanty sulci. Smooth brain. Pachygyra, a few broad malformed gyri varying in size and number. Pachygyra, rare, broad gyri, shallow sulci, grossly unlayered 2, 3, 4 layers microscopically, shallow sulci. Polymicrogyra, an increased number of gyri, some which are abnormally small. Polymicrogyra or micropolygyra, the gross false appearance may. Small gyri, microscopically various from unlayered 3 to 4 layers, fused sulci. Schizencephaly, which many classify as a form of porencephaly, resulting in formation of abnormal slit or cleft in the cerebral hemisphere. Unlike porencephaly, however, which are thought to be result of brain injury, schizencephaly is thought to present a defect of neuronal migration and thus through malformation. Small, closed type schizencephaly. Open lip schizencephaly. Ectopic gray matter, neural heterotopia, usually periventricular and anyway along the migration pathway. Destructive lesion. Porencephaly, secondary defect in cerebral hemisphere communicating with the subarachnoid space, ventricle or pulse. Hydranencephaly, secondary defect affecting most of cerebral mantle, superior, inferior, temporal, and occipital may be spared. Porencephaly is a cyst or cavity in the cerebral hemisphere communicating with the ventricle. It may be developed pre or postnatally. The defect may be caused by developmental anomaly, inflammatory disease of vascular accent such as intraventricular hemorrhage or parenchymal extension. Neurological examination usually abnormal, diagnosed confirmed by cranial CT, MRI, ultrasonography. Progressive hydrocephalus occur rarely with porencephaly. Prognosis variable with few patients develop only minor neurological signs and have normal intelligence. Treatment support. Hydranencephaly is an extreme form of porencephaly which in which the cerebral hemisphere almost totally absent. Usually the cerebellum and brain stem are formed normally and the basal ganglia are intact. The meninges bone and skin covered with cranial fold are normal. Often, hydranencephaly is diagnosed prenatal ultrasonography. Uh, Neurological examination usually abnormal and the infant does not develop normally. Externally, the head may be normal, but when transillumination light shine completely through CT ultrasound confirms the diagnosis. Hemimegalencephaly, malformed cerebral hemisphere. Cerebral hemisphere may be large, small, symmetry. Gyri may be absent, usually large, multiple and small. Microscopic section of normal appearing brain may show disorganization of normal laminar neuronal arrangement. Microscopically moderate to severe motor, mental retardation, and epilepsy often occur with this defect. Disorder of histogenesis, like neurocutaneous syndrome or disorder of cytogenesis congenital tumors. Neurocutaneous syndromes with tumors like NF1, plexiform neurofibromatosis, optic glioma, astrocytoma, neurofibromatosis type 2, schwannoma, meningioma, ependymoma. Von Hippel-Lindau disease, hemangioblastoma, tuberosclerosis, subependymal giant astrocytoma. Neurocutaneous syndrome without tumor like Sturge-Weber syndrome, Osler-Weber-Lindau syndrome. Thank you very much, and I hope you enjoy the lecture. Thank you.